You got it. Okay.
Well, hello. Thank you all for having me today. I'm Dr. Marisha Dunning. I work out of Sonoran University at the Neil Reardon Center for Regenerative Medicine. We are a university, but I also run my private practice out of there. We also have student shifts, so a wide variety of care. I did a 2-year residency under an interventional anesthesiologist and general surgeon by training. So I have quite a wide variety of experience to kind of talk about this today. And so you can see the branding on here is solutions, and the reason why I'm just kind of starting to point people a little bit towards my personal website, just because that way you can understand my own personal philosophy and how I'm going about all of these different things. Because within the realm of naturopathic medicine and all that, everyone has their own philosophy. So if you want to get to know me a little bit more, solutionsregenerativemedicine.com is how you can get to know me a little bit more. And so this right here is a diagram that I've put together that can give you a big overview of regenerative injections. And as you can see, it's a little bit of a combination of some of the mainstream techniques that you may be a little bit more familiar with on the other side with other. And so you can see like local anesthetics are on there, hyaluronic acid, steroids, all of those different types of things are things that I actually do utilize in my practice, and they do have a place. And we'll kind of go into that a little less in detail, but like for instance, something like hyaluronic acid, that's kind of my version, like mainstream's version of regenerative medicine, because there actually are studies to show that it does actually, can actually improve the healing of those joints and doesn't actually stick around for as long as people think it does. And then even steroids can be actually neuroregenerative when you're actually doing spinal injections, or even sometimes just addressing the pain generator, especially with spine injections like epidurals and things like that, that you can actually get people out of pain long term, especially in combination with PT and other things like that, and also can help us to clarify our clinical presentation. And that's where local anesthetics and steroids are very helpful, because if I'm able to target their pain and get them out of pain within the local anesthetic window, and then steroids have a little bit more of a long-term approach, then I can be a little bit more confident about applying regenerative medicine. So I'm not going to just be doing injections in people and not really fully understand their diagnostics. Imaging provides you one level of information, your clinical exam, physical exam, and then we can add diagnostic injections as another layer to help make sure that when we do go in with regenerative medicine, that we're being very targeted and precise. And then you can also see there are other layers here. There's dextrose-based therapies and then orthobiologics. And so there are some overlapping aspects to this graph. And as much as I try to keep things clean and simple by putting in a graphic representation for you all, there's a lot of art when it comes to injection therapy. And so for instance, you see trigger point therapy under local anesthetics, but I also like to add a little bit of 5% dextrose into my mix to decrease some neurogenic inflammation if I'm treating a muscle with trigger points. And we can get more into detail with that. And then sometimes people will use some of their orthobiologics in some of these dextrose-based anti-inflammatories with like vasoplane, nerve hydrodissections, or perineural therapies. But in general, these are the categories I've kind of set out for, with other being more mainstream, dextrose being dextrose-based therapies, whether it's anti-inflammatory to more proliferative or sclerotic, and then orthobiologics, separating these out into different types of solutions that are autologous, meaning coming from self, or allogeneic, coming from a donor or something else. And we'll go into this in more detail, but just giving you kind of a bird's eye view before we dive in. So with the wound healing cascade, this is kind of the basis of how regenerative injection therapies work, is that we're manipulating the wound healing cascade. And there's a lot of theories on how we're doing this with the different types of injectate therapies, but you may be familiar with how this process works. So initially, when you get a wound, you have hemostasis, you're trying to stop the blood, and this is driven by your platelets. And so it's a little hard to see here, but you can see on the bottom here, you have the different types of cells that are going through and telling you this is the main driver or acting during that time period. And so during that hemostasis, which is minutes to hours, that's going to be your platelets. And then your inflammatory phase, this can last from 1 to 3 to 7 days, depending on which literature that you're reading. but this is going to be more driven by your neutrophils and also your type 1 macrophages, and we can get into that a little bit more here in a second, but this is going to be your inflammatory cytokines like your TNF alpha, your interleukin 1 beta, and this is going to drive that initial inflammatory response that most people kind of attribute to the redness, the swelling, and all of those different types of things in that initial acute phase. And so by understanding the true wound healing cascade, a lot of times people talk about things being anti-inflammatory, but really it's more of a manipulation of this actual process and what types of cytokines and cells that you're using, as well as how you're switching from one part of the phase to the next. And then the proliferative phase, which is really when you're looking at chronic condition, this is really where you're wanting to start out, which is at the 3 to 7 day time point to about 3 weeks and beyond. And then there's also the remodeling phase, which can last weeks to months, even like a year beyond. And so then there's a little bit more on this slide that talks about macrophage polarization. I'm not sure if that's something that you guys are familiar with, but that initial kind of acute inflammatory phase is typically driven by M1 type macrophages, and then that type 2 macrophage response is more affiliated with proliferation and is actually more of an anti-inflammatory type macrophage. And that conversion between M1 and M2 is actually what a lot of people struggle with. And so if they're not able to make that switch, then they're kind of getting stuck into kind of a chronic inflammatory cycle and not allowing them to heal and regenerate naturally. And so by being able to manipulate this process, we can help people encourage their processes to become more anti-inflammatory, more proliferative, and actually improve the structure that they have already going on. And it's not this clean thing. A lot of times you have different things that are going on at the same time, but it just gives you a rough model to kind of understand. Next slide. And so kind of what I was alluding to before is that everybody kind of comes in and gets an injection and they want things to be clear and defined, but everybody is different, and this is where the individualized approach to naturopathic, regenerative, interventional pain management kind of comes in, is that we're looking at all of the different factors that can improve or contribute to outcome. And so your patient is one of the biggest things. So if I have a patient that is 20 years old, he's athletic, he eats healthy, does all the right things, I could do a low-level intervention like prolotherapy to kind of help his overuse injury. And maybe I just do one injection and then he's gone. I've had that happen to me many times. But then I get my 60 to 70-year-old patient that comes in that has all of these metabolic concerns, doesn't exercise, doesn't eat right, definitely doesn't sleep right, and then you're doing a dextrose-based therapy. Could it be helpful? Sure, especially my diagnostics like we talked about, but they're likely going to need more of an oomph in that process, or maybe they're going to need some other things to kind of round out, whether it's diet, lifestyle, supplementation, or maybe we need to use more of a powerful solution than prolotherapy. Not to say that prolotherapy isn't powerful, there's a lot of really cool research on that. And then concentration, and so we'll kind of get into the nitty-gritty with that, but with all of these different types of therapies, there is a range of concentrations that you can use, whether that's in dextrose, platelet concentration, or even concentration of the different growth factors, cytokines, other types of bioactive molecules. Structural target. So a lot of times, one of the things that I kind of pride myself on is having a very thorough diagnostic, whether that's diagnosis or biomechanical. And by having that precise understanding of what your structural target is, it really helps to make sure that you have the response you're looking for in a patient. Because a lot of times what I've seen is that a patient will go somewhere, they have these certain things that show up on an MRI, and they're like, oh, you have this disc herniation that's pinching on this nerve, your low back pain, that must be related to that. 9 times out of 10, well, maybe not 9 times out of 10, but a lot of the times, that's not necessarily the case, and that there's other things going on. And so as much as I think that the imaging is great, I look at the whole person, and that each of these differentials that the person has, they kind of get their own little buckets. Like, oh, well, this now has some points towards like a radiculopathy picture, but you know, there's also other differentials and things to consider, and you're kind of working up that whole process. And so that's where, you know, understanding the structural target is important, because if someone else had, like, let's say a PRP injection and they're like, PRP doesn't work, I've had it before, but was it because that were they injecting actually the pain generator? It might have had nothing to do with the actual solution and everything to do with the actual application of that. And so, and then also we were kind of talking about using the correct solutions and the correct actual application of that. Now that you understand the diagnosis, now are we applying the solutions appropriately? And then image guidance. So there's a wide range of image guidance that's used out in the field, and I'm actually surprised on how much palpation guided injections are used, not just in the naturopathic field, but the MD, DO type world on treating a lot of injections. And I'm not to say that palpation guided injections don't have its place, but if you're able to be more specific with your target, and I personally have been trained in fluoroscopy, and I'm also a diagnostic ultrasonographer, I can use the gold standard in treating that, as well as making sure that I'm having the proper diagnosis and not being able to read what's going on, but then now I'm also able to identify that structural target that we've determined as the cause of their pain and treat it in our image guidance. And also the safety factor. I'm very much confident in my safety and my efficacy when I'm doing things under image guidance in that way. And so keeping those different things in mind when you're looking at these different types of injecting therapies. And so we'll start off with the dextrose model. And so I have this listed out in a few different categories here as anti-inflammatory, inflammatory, and sclerotic. This may be a little bit of an outdated model. There's a lot of new and upcoming research to kind of go into a little bit more detail on how these different types of therapies are working. And there's a lot of research to suggest that it's more of a cell-mediated, cell receptor type pathway. But just to kind of help you guys kind of explain a little bit of these different categories, and this still is kind of the main thought process around that, I did want to kind of introduce you to this model. So in the anti-inflammatory section, there are 3 different types of techniques. And so it's challenging because there's solutions and techniques. And these techniques that I'm going to be talking about, technically you could use other solutions for it, but they are commonly used with the dextrose model. And so perineural is one of them. And this is an initial concept that was initially introduced by Dr. Liftoff. And there are a lot of different approaches that can be used to apply this, but perineural, meaning around the nerve. And this is a palpation-guided approach that you're targeting the superficial cutaneous nerves that are involved in pain generation. And then there's nerve hydrodissections where you're actually using ultrasound guidance to actually target those nerves, and then fascial plane, which is where you're kind of going through the fascial plane and kind of decreasing adhesions and treating nerves that way. And so that's the anti-inflammatory model. If you have less than 10% of that solution, those are things that can be kind of treating those cutaneous nerves. The inflammatory model, this is where you're looking at prolotherapy, and that's where you're kind of re-initiating the wound healing cascade. Like I said, you can actually have this proliferative effect with actually lower concentrations of dextrose, is what a lot of the research is showing. But when you're talking about prolotherapy, typically it's between that 10 to 30%, but you may actually be able to get a same, if not better, response with some of the previously thought anti-inflammatory solution amounts. But if you're going out to that 30% range, I think everyone can agree that you're getting into more of the sclerotic, fibrotic range. And as much as that doesn't sound like a good thing, there are certain scenarios that can be helpful. And that's why I always teach, know your medicine, know your response, know the mechanism of action, because there's always a scenario, or usually a scenario, let's not be, that it can be helpful with. So there are certain, like, let's say if someone has a cyst, we've actually had a lot of great success with treating cysts with a little bit higher amount of dextrose concentration and preventing them from having to get surgical interventions by using that higher range of dextrose. And then also, like I was saying before, you can kind of mix things. So trigger point therapies are targeted for more muscles, and you can mix that with like 5% dextrose, which is a lot of times what I do, just so that I can get a dual response with the trigger point and the 5% dextrose. Next slide. And so these, this is going into a little bit more of the low-dose dextrose model. And so we had talked about the perineural, the fascial plane hydrodissections, and the nerve hydrodissections. And I have some different, I wish you guys could see this a little bit better to be able to kind of go into the details of it. But perineural, it's a very simple injection. It's a 5% dextrose solution that is injected just subcutaneously underneath the skin. You're using, typically speaking, a 27 gauge or a 30 gauge needle that's 1/2 inch. The safety profile on it is really great. 5% dextrose, it's an isotonic solution. It's hard to get in trouble with this type of therapy, and the therapeutic benefit for it is massive. Because a lot of different types of pain profiles, even if, let's say, someone has osteoarthritis, I'm not going to necessarily reverse their osteoarthritis with a 5% dextrose solution, but there's a lot of neurogenic inflammation and pain that goes along with any type of pain condition. And so if you're looking at what's called Hilton's Law, is that if you're treating the cutaneous nerves, those nerves are connected to all of the muscles, the joints, the bones, and also going back to things centrally. And there also is like a CSF type flow that allows this whole network to kind of communicate with one another. And so something that's as simple as treating underneath the skin can actually have a profound effect on the entire system. And there, you can have, but usually speaking, perineural is targeted to constriction injuries. So if it's around like fascial planes where they're having adhesions around the nerves, or maybe it's around a bone or a hypertonic muscle, that you're able to kind of address the more neurogenic inflammation in that way. And so if you look at this model here, we're injecting just above the deep adipose tissue and muscle, and that's going to treat it at the base where you're getting that cutaneous nerve piercing the fascia and treating that entire range of nerves. And so understanding cutaneous nerve distributions and where they pierce their fascia, you can be very specific on those on your treatment protocol. And just some different fun facts, that a nerve that's hypoglycemic can increase their pain firing rate by 652%, which is a ridiculous number. And that's where a lot of times when I have patients in my office, I treat with 5% dextrose and they have a local anesthetic-like effect where it's like they had pain. A few minutes later, they don't have pain. It seems like an analgesic effect, but it's because you're understanding on a physiological level exactly what's going on, treating the root cause on that physiological level, and they're having a profound response in your office. And then even things like ischemia with reduced blood flow to those nerves can increase by 220% with pain firing rate. And so these other types of therapies that we're talking about here, nerve and fascial plane hydrodissections, these are just kind of taking that concept of using 5% dextrose, but in a little bit more of a precise manner. So right here, you can see that this is an ultrasound cross-section and short axis of the median nerve, which I have highlighted here. And so if I were to do a nerve hydrodissection here, I would never put the needle in the actual nerve itself or in the epineurium, but you're going just around it, below and above it, and then you're creating space around it to release those fascial adhesions, as well as nourishing the nerve to kind of look into some of these other principles. And so there are a lot of additional mechanisms of action that are being explored on looking at substance P, calcitonin receptor gene peptides, as well as other cell receptor models on how this whole process works. But these are just kind of some things that have been looked at in the research for mechanism of action. And then fascial plane hydrodissection, essentially the same concept under ultrasound, finding the affected fascial plane that you're wanting to treat, and then spreading along that fascial plane, and you can actually see that separation happen very cleanly under ultrasound. Next slide. And so then now we're going to look at higher dose dextrose prolotherapy. Like I said, this is supposed to be more of a proliferative type therapy and could technically happen at a lower percentage range, like 5% or below. But we'll talk about it in the traditional sense of 10 to 30%. And typically speaking, what makes it prolotherapy is using that percentage of dextrose. And then there's other dilutants that people use. So a lot of times people will use local anesthetics within that short or long, or they might just use normal saline, but it's the dextrose part of it that makes that the prolotherapy, and those other things are just a little bit more of art within using the different types of solutions. And then you can apply prolotherapy, because prolotherapy is more of an idea, and then you can apply that with palpation, fluoroscopy, ultrasound, and your imaging of choice. And like we were saying before, mechanism of action is slightly controversial at this point in time. Originally it was thought to be an osmotic irritant. So we had talked about 5% dextrose being an isotonic solution, and as you're kind of getting into these other ranges, you're getting into more of the hypertonic solution, and that can cause cell death, which it is happening. Cell death can be happening at higher amounts, and that could be technically still part of it, creating the inflammatory model. It's just not explaining the entire effect that we're seeing with patients. Next slide. And so then trigger point therapy, this is more of using your local anesthetics, and local anesthetics also have a therapeutic benefit in and itself, because when you apply local anesthetics to someone that has a chronic pain condition, then you can also reset those pain cycles. And the more you have, kind of what we talked about with central sensitization, maybe not now, but earlier, that once you have those pain pathways continue on, if you're able to shut that off, you can actually, that in itself can be therapeutic. And then also you can have the mechanical disruption of different fibers, whether that's, and that could also be part of their pain picture. You're improving blood flow. Local anesthetics is a vasodilatory, so improving that blood flow, kind of like you would use a heat compress on an area, you can kind of use the local anesthetics to kind of do that as well. And then also can help with decreased inflammation and neuromodulation, kind of what we were talking about with resetting pathways, but also if you're including some 5% dextrose in that solution, you can also augment that anti-inflammatory effect. And so this is kind of the Travell and Simon's kind of picture of what a trigger point pain pathway could be, with different adhesions in the muscle that can be caused for many different reasons. Next slide. And so now that we're going to get into more of the orthobiologics, kind of switching from dextrose-based therapies into biologics that are geared towards orthopedics, and that's kind of what that's supposed to mean. So natural substances derived from living organisms to treat musculoskeletal conditions, like we had said, allogeneic from other, autologous from self, and we'll kind of break down whether it's blood products, fat products, or more of the allogeneic, which actually I feel like a lot of people are more familiar with some of these when it comes to the regenerative side of things, just because it's a little bit more easy to apply. But my personal preference is actually the autologous therapies. Anything that's going to come from yourself, your body is going to do better with, but some of these other therapies can provide a little bit more access to these different types of therapies, but these are actually more highly regulated, and it's a lot easier to do a lot more of the autologous type orthobiologics. Next slide. So that's kind of what I'm going to get into this next slide, are regulations. Regenerative medicine is highly regulated, and so when I'm talking about this in this discussion here, this is more from an educational standpoint, because a lot of people throw around the term stem cells very loosely, and that's really not something that can be, it's not really an approved term to be used unless you're in a clinical trial and you can actually say that, yes, I have these amount of stem cells, and I can kind of prove that out within a clinical trial. And so there are specific regulations that allow us to use regenerative medicine, and those are outlined here. And so typically speaking, when I am using regenerative medicine in my practice, I'm working under the HCTP 361, and that kind of talks about that if you're going to be using these different types of solutions, that it needs to be for homologous use, minimal manipulation, and same-day procedure. And so those are what allow us to use these types of things. And there's a little bit, and then the other aspects with the donor tissue, that making sure that you're using it for those things. And so I'm not necessarily for or against the use in different things, and so it's up to you in your interpretation of the different guidelines to be able to use these therapies. So we're going to be talking about it from more of a scientific perspective. And so, starting with PRP, platelet-rich plasma, is also a very, very popular orthobiologic that is derived from a simple in-house blood draw that we then centrifuge down and isolate the platelet-rich plasma. And in this graph here, when you are doing something like centrifugation, it separates out the blood components based on density. And so this buffy coat that you see here, which is the line between the hematocrit and the plasma, this is where you're going to get a lot of the platelets, white blood cells, and all of those things. And there are different ways to process and different types of techniques on applying it to different conditions. So there's leukocyte-rich and leukocyte-poor PRP. And everyone has their own idea on which one should be used for which conditions, but in general, kind of a way to think about it is that if you're wanting more of an immune system response, more of a white blood cell response, more of an inflammatory response, which could be used in like an acute condition to kind of support their pathways, then you could use the more leukocyte-rich. The leukocyte-poor is a little less inflammatory and could be used in more chronic conditions, but even in my own practice, I still like to use the leukocyte-rich, which is a little bit more of a profound inflammatory response, even in some of my chronic conditions. So like I was saying, a little bit of an art when going into that. And there are, in the platelets, which is the main driver of PRP, they have something called alpha granules in them. And the alpha granules of the platelets essentially are a sack of different goodies with growth factors, cytokines, and all of those things that are, if you remember the wound healing pathway, essentially all of those different signaling factors are concentrated into those platelets. And so this is where I kind of describe PRP, is that I'm going right to a source of healing in the blood, concentrating it down, and then injecting it into the affected areas. You're not working with your body's recruitment system to be able to bring in your healing pathways. You're concentrating it down and putting it into the area. And then we kind of talked about leukocytes, kind of like modulating inflammation and tissue repair, and kind of helping to remove debris and different things of that nature, which is more important in kind of an acute picture, because a lot of that initial aspect of an injury kind of happens more in an acute injury situation as opposed to someone in more of a chronic condition. Next slide. All right. This is, I didn't know how much time we had, so I wanted to offer kind of a quick, this is like a 3-minute video on actually how PRP is processed in the clinic. This is the kit that we use, just based on the research that has a really great concentration number, as well as it adheres as best as it can to like the closed system aspect of things. So once again, looking at different guidelines and regulations, that if you're going to be doing these types of procedures and blood draws, that it needs to be in a closed system. And so this is able to do that. So a lot of times when you go to different practices, how they're able to manage cost is that they use manual processing of PRP, and that's not something that we do in our clinic, just to kind of provide better efficacy, but also just having a cleaner protocol in how we do things and abiding by regulations. And so this is MSite Pure 2. If you'd like to click the video, we can watch this real quick. So we can go back one thing. I don't think the video.
Is there
should be a little play button. If you click in the center, go around the center. Does it not show it up?
No, I don't.
Maybe it's here.
Yeah, maybe if we.
Oh, maybe go ahead.
Yeah. Oh, there you go.
Welcome to the next generation of Pure 2. In this video, we will prepare platelet-rich plasma with the ease and accuracy of Pure 2 120 milliliter platelet concentrating system. To begin, remove the red cap from the needleless mouth port of each separator device. Swab each port with sterile alcohol before and after accessing with a sterile syringe or cap. Fill two 60 milliliter sterile syringes, each with 6 milliliters of citrate anticoagulant. Then draw 54 milliliters of blood in each syringe, filling each syringe to 60 milliliters. Attach the 60 milliliter blood syringe to the needleless port of each separator device and slowly inject the anticoagulated blood. Make sure each device has equal volume. Place both devices in the centrifuge rotor at opposite ends. Follow the protocol settings provided in the Pure 2 IFU insert. Close the centrifuge lid and press start. After centrifugation, platelet plasma suspension, or PPS, will be separated above the red blood cell layer. Attach a sterile syringe to the top port of each device and aspirate the platelet plasma suspension. You may need to repeat this process until all of the PPS is collected. Remove the clear cap from the concentrator device. While holding the concentrator device in an upright position, transfer the platelet plasma suspension from both separator devices
And so that
into
first
it.
spin is a soft spin, so it's just separating out red blood cells from the plasma, and so here we just have the plasma suspension, and then once this process at the end, this is a two-spin process that allow the separation within the actual plasma.
Counterbalance the concentrator device with equal volume. And place into the centrifuge rotor at opposite ends. Follow the protocol settings provided in the Pure 2 IFU insert. Close the centrifuge lid and press start. After centrifugation, the platelet buffy coat layer will be clearly visible at the bottom of the concentrator device. Attach a sterile syringe to the needleless port of the device and aspirate the
And so
platelet port
because the
plasma
tubing is
in
above that
approximately
first
14
part, it's
milliliters
taking out
or
all of the
desired
solution on the
amount
top,
of the device.
just leaving the PRP, which is
Resuspend
what's on the bottom.
platelet buffy coat back into the plasma by rocking and swirling the device back and forth. Do this until all of the platelets have been resuspended into the plasma solution and is no longer
So this is
visible at the
kind of
bottom the
showing what if you
device.
wanted a leukocyte-rich
Attach the
version
syringe to the needleless
of
port
doing
and tilt the device to
doing PRP.
aspirate the PRP. This concludes our processing video for Epsite's Pure 2 120 milliliter platelet concentrating system.
And there are a lot of different versions of these types of concentrating kits. This is just one that we particularly found that works really well, and kind of meets guidelines as well as have a really great efficacious amount of platelets within it. And we do third-party testing randomly just to kind of test out the claims that we get from all of these different things, and they stick with what they say. So, next slide. And this is just kind of the same company, and just kind of going through for more of a graphical representation of going through and pulling out the plasma and reconstituting it into the buffy coat. So the next one is alpha-2 macroglobulin, A2M. And so we're kind of talking about different blood products. And so the other one, we were looking at isolating platelets. So even though this kind of starts off as a very similar process, it's different with the end product of what you get. So we actually don't care about the platelets in this situation. We're actually looking at the plasma. And so the system that we use a CareStream system that there's different ways of doing it, but essentially you're dehydrating out the plasma. In the system we use the dehydration aspect with using a filter that separates things based on size. And so alpha-2 macroglobulin is a bigger molecule than some of the other things that are in the plasma. And so by separating out with centrifugation and then separating it out with a filter, and then also in our clinic we also use gravity within the system that we have, then you're able to get a concentrated alpha-2 macroglobulin product. And so what is alpha-2 macroglobulin? It's, like we said, it's something that's in the plasma that has actually been researched to show that it helps with decreasing certain metalloproteases. And so metalloproteases and admins have been known to degrade collagen and connective tissue. And so this is something really great for someone with osteoarthritis, but it also has really great anti-inflammatory effects by blocking these types of molecules, and can also has been shown for cartilage preservation, as well as kind of helping with the wound healing environment. And so by getting a lot of these different inflammatory markers within that area that you're treating, neutralizing them can then, if you're wanting to kind of start off with this, help to improve the environment, then going back in with another type of injection can improve your response. Because some people, like we were talking about before, they have these hyperinflammatory responses. They're really stuck in that first phase of wound healing, and this can kind of help push them into some of the later phases of wound healing. And then by improving that environment, then now we're going in with our other types of regenerative injections and can potentially give them a better response. And so those are some different ideas on how you would apply this, and it's really targeting at connective tissue, joints, and how you choose to apply it is up to you. Palpation, fluoroscopy, ultrasound. This is something that can be used with different types of injection models. And then we're going to get into the stem cell things. Like I said, I'm just using the word stem cells here from a physiological anatomy type perspective, just to kind of help you guys understand what it is that we're talking about. And so when people typically think of stem cells, where do we find stem cells in our body? We find stem cells in our bone marrow. A lot of people don't realize that fat is a huge reservoir of stem cells, and it's actually better than bone marrow. And then also there's perinatal tissue. So you're looking at like placental tissue, amniotic fluid, all of those different types of things. And then people talk about stem cells and getting them from these different types of locations. This is actually how your body heals. You have periocytes or stem cells all around your vasculature, floating around in your blood. So to think that these aren't things that are foreign to your body's ability to heal, it's actually intrinsic to those processes. We're just able to potentially concentrate them, if you're in a clinical trial, in those scenarios. But even still, as much as we talk about these types of stem cells, they aren't necessarily the main driver in a lot of situations for healing, because we'll also talk about exosomes and other things like that. But even with our platelet-rich plasma model, it's the growth factors and cytokines and all of those other signaling molecules that are just affecting the wound healing cascade and helping you to get those responses. And something else that I also like to kind of talk about is, because people think stem cells, they think, oh, what about the teratogenic potential that could potentially be correlated with that? And there's not really research to support that, and especially because when you're even in the perinatal tissue, those are adult stem cells that you have around the perinatal tissue. You've already kind of gotten out of the more pluripotent, now you're getting into the more multipotent. And so these are mesenchymal stem cells that we're talking about, and mesenchymal stem cells have a very definitive tissue that they can turn into. So that's where you're looking at bone, cartilage, nerve, and connective tissue, soft tissue, things of that nature that it can turn into. And there also has been some research to talk about immunomodulatory potential of advanced orthobiologics, and so you can upregulate certain parts of your immunomodulatory pathway that it can actually be beneficial for things like autoimmune conditions and helping to improve your immune system, and not just looking at the actual potential of the cellular outcome. You're also looking at improving the environment and improving immunomodulatory effects. And what we had also kind of talked about, these are a rich source of extracellular matrix and collagen, hyaluronic acid, all of those things. And this is really what we're looking at when we're talking about some of these advanced orthobiologics, is they can provide structural components to these areas. And so when I'm thinking about fat is not just a rich source of all of these bioactive molecules or stem cells, it also acts as structural support. So when I inject things like fat into an area, I'm also providing cushioning in that area. Next slide. And so the first procedure that we'll talk about is bone marrow aspiration. And this is where it would be also an in-office procedure where, typically speaking, it's drawing bone marrow from like kind of the back around the ileum, right around the PSIS. And we do this under fluoroscopy guidance. And you tap into the different areas of the bone. There's certain areas of the bone that are better to draw blood out. We go into the area that's called zone 6, and that has a higher amount of bone density so that you can safely pull out bone marrow. And so this is kind of going back to what I was kind of alluding to, is that there has been research to show that you do lose your mesenchymal stem cell concentration as you age. And so someone that's over 40 years old, this might not necessarily be the best option for them if you're looking at kind of concentrating their mesenchymal stem cells. However, there are certain scenarios where maybe this might be a better option, where if you're looking at bone healing, or maybe you do have a younger patient that is a little bit more lean and you're not going to be able to do a fat harvest from them, this could be a potential option. Micronized fat, this is by far our favorite in our office, and out of all of the different procedures, this is the most efficacious that we have found. And this is where we would harvest small amounts of fat from either the abdomen or the lower back, typically the abdomen. And we use a closed system for it, but there are different manual processing systems like lipogems that people use to extract fat from the abdomen. And once you extract it, then you can mechanically resize, and that's what we're calling it micronized fat. There are other different models where people use enzymes to kind of degrade the connective tissue and to release the cellular components and bioactive molecules from the connective tissue. That's in our mind a little bit more than minimally processing, but that could definitely be something argued for, but we just stick with the micronized fat and mechanical reprocessing. And honestly, I actually like having all of the structural components, because that's where we're actually supporting the actual cushioning and providing that scaffolding for the area. And like I was saying before, really when it comes to these different types of solutions and what you're applying to it in imaging, it really just depends on what you're treating and how you're wanting to go about it. And so I guess one more point, and that we were talking about bone marrow decreasing its cellular content as we age. Fat preserves it. And so even if I were to take fat out of a 70-year-old, their cellular content and their architecture is going to be similar to someone that's younger. And so this is a great way to offer someone a profound effect to use someone's fat. And who would ever think that we would actually start liking fat? I feel like fat has been given such a bad rap for such a long time, and actually there's a lot of healing potential in fat that we're now learning about.
I was going to ask, how many patients joke when they're getting this done, like, keep taking more, not?
Oh, almost all of
Everybody,
them.
right?
You can take as much as you want. It's like, I'm sorry, you're not going to even notice how much I took out of your abdomen. Because usually it's like around like 2 ounces of fat or so that we take out, which is not enough to really make someone happy.
No.
But it's funny because
I'm
I have
sure the jokes are great.
some of my leaner patients. It's like, you probably never had your doctor tell you to gain weight, and I'm going to tell you to gain weight, and it's really funny.
Oh, that's so funny.
And then donor tissue. And so there are many different types of donor tissue. I'm going to just talk about a few categories of some popular ones. Exosomes is a really popular one. And this is where you have the mesenchymal stem cells, or cells in the area that are secreting different types of vesicles, proteins, lipids, and these are kind of what we had talked about, the signaling bioactive molecules that are part of the repair process, and they're kind of isolating those out and injecting those. And then perinatal tissue, this is like umbilical cord, Wharton's jelly, placental tissue, amniotic fluid, and these are derived from young, healthy pregnancy, so really not like an ethical concern from any of those different types of things. And there's thoughts that there might be organelle transfer in some research when you're using these different types of tissues, and so if you're providing young, healthy cellular tissue, then they can provide more of like a robust response in that way. And then let's see. And then there's stromal vascular fraction. So this is going back to the fat. There are different ways to get stromal vascular fraction. So this is where we're separating out the bioactive molecules from the structural components of the connective tissue. You can do that with centrifugation, which is more of a minimally manipulated process, or there are people that use different enzymes to kind of degrade the collagen. And so kind of general advantages: time efficient, less painful, but there's a lot more scrutiny with the regulatory uses of that, and so yeah. And so this kind of concludes
Cool.
my presentation. So if you want a little bit, this is my contact card, and if you want to look at some of the other things that I am posting online, so I do have all the different social media platforms, and then my website that I'm starting to post a little bit more about all of these different types of things if you'd like to learn more about it. So I'm going to now open the floor to a little bit more of questions.